Okay, hello there. It's Dr. Marston, and we are uh, doing the uh, class on anxiety disorder this week, anxiety disorders. Um, so I wanted to, by the way, as a side note, I guess to start, I did read your paper on depression. I thought it was very good. Um, Only suggestion I have for future papers, I wanted to bring this up now in case you saw, in case you read the, I'm sorry, in case you watched this video before you did your next paper, is I'd like you to incorporate a little bit more um, into saying if you were the therapist, how you might use that information. It doesn't have to be a big deal. It could just be a couple sentences in a separate paragraph. But I would like you to end each paper with just a brief summary of what you think you might take from the material you read and use it as a therapist, how you think you might use it in a clinical setting. I really would like to see that in your paper because I'm hoping you can take the material you're learning from these papers and apply it when you're actually a therapist. So it's not just an academic exercise where you're learning things so you can, you know, spit it back out if asked to uh, define different disorders, but that you actually can use it in some sort of therapeutic setting if the situation called for it. So just going more into a little bit how you would make practical use of the information would be something I'd really like to see in the papers. Okay, moving on though, we're talking about anxiety disorders this week, and I'm looking at a screen right here on my notes because what I would like to do is spend part of the session or part of the class, as I often do, on talking about the definition of anxiety disorders, at least as it is summarized in DSM 5. Now, DSM 5's category of anxiety disorders actually takes up one of the larger sections. There are nine of them. And I want to talk about each one a little bit, nine categories of anxiety disorders, and then there are different specific diagnoses under each category. But here are the nine: separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, panic disorder, agoraphobia, which is seen as a more generalized type of phobia than the specific phobia, generalized anxiety disorder, substance or medication induced anxiety disorder, and then anxiety disorder due to another condition. And I want to talk about each one separately. And then we'll go into what is anxiety disorder, what makes it different than depression, that sort of thing. Uh, but with separation anxiety disorder, uh, it's a problem that impacts the person because they are fearful or anxious about separation from an attachment figure to a degree that it is developmentally inappropriate. So, an example of this might be a teenager who gets very upset if his mother has to be gone for more than a few minutes, gets very anxious, gets very on edge, maybe even agitated. Um, Now, that sort of anxiety can be, or that sort of difficulty could be reflected in the person seeming more anxious or more agitated, or it could be reflected in the person having nightmares, or um, might be reflected in the person. um, having difficulties concentrating while the person is away. Now, notice how in this example, I bring up specifically uh, the case of a teenager who is upset if the mother has to be gone. That's because that's a very important part of this uh, beyond of it being a condition if it is developmentally inappropriate. You might expect a 4-year-old or a 5-year-old having difficulty if their parent has to be gone for more than a brief period of time. But a teenager, you would expect to be able to handle that sort of separation better. So that's what makes it a disorder when it is developmentally inappropriate. And um, for some of these conditions, it's that developmentally inappropriate part that becomes relevant because children often experience a good deal of anxiety when they have to deal with changes or when they have to deal with separation. It is only when you would expect that level of anxiety to have dissipated, the person to have become better at dealing with the separation, that it becomes a condition, it becomes a disorder. So, very often with anxiety disorders, there is that developmental consideration where you have to wonder, well, is it um, more than you would expect given the individual's age and developmental level? So, that's separation anxiety disorder. The next category of anxiety disorders is selective mutism. Selective mutism. And this is a situation where the individual um, doesn't speak in certain social situations. So um, it is not that they are unable to speak because they do speak in other situations, but in certain social situations they do not speak. The most common example where I've seen this, and I've worked with a number of children who have selective mutism, is school. They will talk at home, um, but they will not talk in school. Now, in the situations where I've dealt with individuals with selective mutism, that inability to talk will transfer over to me if I'm doing an evaluation, but not stay there if I'm doing the therapy. A lot of times with um, kids I see with selective mutism, I may be asked just to evaluate them. But there are also times where I will see them in therapy. And what's interesting is with therapy, I often can get the individual to talk with me, or even if they won't talk with me. One case where I was not the therapist, but I was providing supervision, was with an individual that it never did get to the point where the client could talk to her, but they would do therapy almost entirely through electronic messaging, emails, texting, that sort of thing, because the person could share more and felt more comfortable um, talking or talking um, if it was through electronic communication, but verbally they they weren't able to do it. So selective mutism, I bring those up as examples because you can really see where the term comes from there. Selective mutism. It is only in certain social situations. And most often it is in school. Will the person uh, cannot talk, does not talk in school. I've known kids who, for an entire grade, entire second or third grade, they don't say a word in school. Sometimes kids grow out of it. The cases I'm thinking of individuals who didn't talk through one grade, the next year they did talk. They felt comfortable. So it could be a temporary thing, or it could be something that lasts throughout a good deal of school. Uh, Specific phobia. This is when a person is anxious or avoidant of specific objects or situations. Um, the fear, anxiety, or avoidance, and I'm reading from here, is almost always immediately induced by the phobic situation to the degree the that it is persistent and out of proportion to the actual risk uh, posed. Um, so this could be someone who's afraid of spiders, afraid of snakes, um, fear of flying, fear of heights. Those are all specific phobias. And it is that issue. Uh, what is the word? Oh, out of proportion to the actual risk um, posed is a subjective term, but it's also what makes it a phobia. For instance, if someone's out in the woods and they see a spider, uh, their fear may be legitimate. In fact, sometimes people will criticize the whole idea of spider phobia and snake phobia because they'll say, well, you're supposed to be afraid of spiders and snakes. That's evolutionary. That's probably just, your animal brain kicking in and saying, hey, that could be dangerous. Um, so it depends on the situation. If the person can't function in any sort of woods environment because they're that afraid of spiders or that afraid of snakes, especially if they live in, you know, um, areas where there are dangerous snakes, but not that many. Um, you know, if you're out in the trails of Arizona, um, there are a lot of rattlesnakes. You probably should be afraid of snakes, but so it's out of proportion. It's interesting too. It depends on the environment where you live. My understanding, I've never seen this outside of television, but my understanding is that in Australia, it is very common to see spiders that are rather large, and apparently they're harmless or just large. Um, and so, if you were living in Australia and had such an aversion to spiders that you couldn't even imagine being around one, then that's probably going to paralyze you. So you're probably not going to be able to function at all. Um, Fear of flying is one that I will tell you. I've been a therapist. Let me just give you a personal account to show you. I've been a therapist at different levels for over 20 years. I've never had a client whose only problem was a phobia. It was interesting when I was in college in graduate school. That sort of approach was taught a lot. But I've never had somebody walk in whose only problem was uh, that they couldn't function because of fear of spiders, or they couldn't function because of fear of heights. It's not that common for it to be the person's only problem. They may have anxiety that translates to another problem. I had one client once who insisted she was coming in um, because she had a fear of escalators. So I worked with her, and this was early on in my career. So I worked with her on desensitization, and I'll talk about that in a minute. Um, Getting her to be more comfortable with her anxiety of us. But then it turned out, as we talked, her anxiety was broader than that. And what ended up being the case is she often had to have her son help her if she needed to be at a mall or something, because then he would help her with the escalators. And she felt very distanced from her son. So her anxiety was sort of increased because the more problems she had with the anxiety, the more she could call on her son to help her. And that was really the only way she felt she could get any attention and any time with her son. So that was just an example of how I'm not saying phobias aren't out there, just very often my experience has been that when someone has a phobia, there's often something else going on in their life. But there are people with phobias, and um, very often what you will see when it comes to a phobia is will um, the phobia will interfere with something they need to do. So even if you can explain the phobia, um, it is still a problem for the person. The most common way that occurs is fear of flying. You know, it's interesting just from a purely philosophical um, point of view. People will argue fear of flying is legitimate to consider a phobia. I mean, flying is not what we would call natural. I mean, it's this piece of equipment that goes up in the air. Um, Lands, it's not something we can do ourselves. It's something that human beings literally couldn't do for thousands, if not millions of years. And then, um, and you still couldn't make the argument uh, that we actually fly. We get in a piece of equipment that flies. Um, so there's a philosophical argument that, well, fear of flying is just, yeah, again, evolutionary. I mean, we're not supposed to be flying. It's not a natural thing. But there are people who literally can't work if they can't fly. You know, you get a job and you're set for everything, but uh, you have to fly for up until the pandemic hit. Um, Sometimes 12 times a year, I'd fly out to do seminars on autism, and I liked them. They were a good thing. They were part of. I was being paid for them, and paid uh, enough that was worth my while. And but I literally couldn't have done them if I couldn't fly. Um, and so um, it is something that sometimes people. That's an example, I guess, of where you would see a phobia come through more, which is not that you couldn't explain why the person's afraid of something, but it's interfering a lot with what they need to do. Um, a person may, person, I guess an extreme example would be a person with a severe spider phobia who works in a zoo. Um, Probably something they got to learn how to figure out. Social anxiety disorder comes up when the person is fearful or anxious about social situations or avoidant of social interactions. Um, as there often is with a lot of these anxiety, there's a cognitive aspect to this. Um, this involves the person being avoidant of situations where they feel they might be scrutinized. So very often the anxiety comes about because the person is fearful that they will be scrutinized. And some examples include unfamiliar people, situations in which the person may be observed eating or drinking, um, or situations where the person has to quote unquote perform in other people. Um, so um, very often um, uh, it is because the person is afraid of being judged. Now it's interesting that most of as a matter of fact, phobias are the only anxiety disorder that doesn't have a specific cognitive aspect tacked onto it. Social anxiety has to be with fear that the person is going to be judged. Separation anxiety is fear of being separated from an important person in their life. Selective mutism is fear of speaking in certain situations but not others. So there's an internal mechanism that's part of the diagnostic criteria, except for phobia, where it's only just being fear afraid of the one um, specific type of situation with no specific internal mechanism being part of the criteria. Panic disorder, and you hear about a lot about this, so I'm going to read the definition. The individual experiences recurrent, unexpected um, panic, anxiety, and is persistently concerned about having more panic attacks um, uh, in the future. They are panic attacks are considered to be abrupt surges of intense fear or intensive discomfort that reach a peak within minutes um, and are often uh, accompanied by physical and or cognitive symptoms. So um, it's this that's really what a panic attack is. It's an intense rush of anxiety within that builds within minutes. Very often people will describe it as occurring for no apparent reason. uh, it doesn't have to be no apparent reason. It could be the person may know the types of situations that are going to bring on panic attacks, or they may not uh, know what led to the panic. So um, panic attacks are a rush of anxiety, um, and where the cognitive aspect comes in is very often after having a panic attack, the cognitive symptom would be fear of another uh, panic attack. Other cognitive symptoms that it can be included is, fear of losing control. That's often what leads to fear initially with panic attacks is fear that something is going wrong. The person's losing their mind. I'm going crazy is often how people will describe panic attacks. Agoraphobia occurs, the next one, which is agoraphobia, um, occurs when the person is fearful or anxious about two or more of the following situations: using public transportation, being in open spaces, being in a closed spaces, standing in line, being in crowds, or being outside of the home alone in other situations. Um, and so the person often becomes fearful or anxious in two or more of those types of situations. Um, Generalized anxiety disorder occurs when the person is anxious, uh, just generally anxious, a large percentage of the time. Um, so the person may be worried about specific things, work, school performance, but what's here is the anxiety stays. It's there for a long period of time, and it's very difficult to control. Some of the physical symptoms that can be associated with generalized anxiety disorder include restlessness, feeling, quote, on edge frequently, being easily fatigued, difficulty concentrating. People will often describe the feeling as their mind going blank, being easily irritable, muscle tension, and sleep disturbance. So now those symptoms were all symptoms of anxiety, but the issue with generalized anxiety disorders, the anxiety lasts. Um, Notice that with the other types of anxiety, um, the anxiety occurs in certain situations, but tends to go away once the situation or the panic is over. Um, but um, generalized anxiety disorder, the anxiety tends to stay. Um, Substance or medication induced anxiety disorder um, is anxiety that is due to some sort of substance um, abuse or withdrawal from a substance. So it could be because of the substance that the person is using, or it could be withdrawal from a substance. I will tell you that where I have seen anxiety disorder specifically related to a substance the most has been in clients I've seen who have used LSD or some sort of hallucinogenic. They will be caught so off guard by what happens that it will often cause a lot of anxiety, even if they've used it only once or twice. In fact, I'd say specifically if they've only used it once or twice. People who use LSD on a regular basis uh, have not necessarily developed anxiety because they've gotten used to it. But individuals I've known who use LSD or other sorts of hallucinogenic once or twice, oftentimes, well, where I've seen someone with a substance induced anxiety disorder, that's been the situation where I've seen it the most has been with the use of LSD. And I've actually seen it to a certain degree, maybe a bit more, because there's been this I don't know what you call it. I guess there's been this sort of system developing called microdosing, where some people have started treating their own emotional difficulties with very small doses of LSD or other hallucinogenics. Um, Now, that's actually been getting a lot of press. There've been a lot of write-ups about it. There's a whole book on it that I think was on the bestseller list. But most of the time, uh, these individuals are doing it completely on their own. It's not like they're under the guidance of a trained professional, however that might be defined, but they're kind of doing it on their own. So a lot of times, these individuals who microdose at the beginning cause themselves a lot of anxiety because they use too much and they throw themselves into hallucinogenic experience. So there's a lot of anxiety. I can also say that where I've seen it occur a lot um, has also been individuals who took a hallucinogenic like LSD and didn't know they were taking it. And specifically, where that's come up is um, they bought marijuana illegally and then smoked it, and it turned out that the marijuana was laced with LSD or some other hallucinogenic. So that's another example of how um, a substance like LSD can induce an anxiety disorder. So it could be because a person uses it and just doesn't know, isn't ready for the experience, like with LSD, or it could be that they use something that was laced with LSD and didn't know that was happening. Okay, and then the last one is anxiety disorder um, due to another medical condition. This is basically where uh, anxiety comes up as a result of another medical condition. Where I have seen this come about um, the most would be with individuals who have respiratory disorder, um, and so they're starting to have trouble breathing, and the breathing problems cause them difficulties with anxiety. Some other diseases that can have anxiety associated with them are seizure disorders, metabolic disturbances like B12 um, depletion, uh, congestive heart failure, hypothyroidism, hypoglycemia. Those are all examples of conditions that can lead to anxiety disorders. Um, and then there is, just to let you know, there is a category, I'll just bring this up here, of other there are two other categories as there are with all of these. With all the DSM-5 categories, there always is a category of other specified anxiety disorder and unspecified anxiety disorder. It even says in the DSM-5, as I talked about before, you are encouraged to not use those very often, uh, but they are used. They are there. There's other specified anxiety disorder and then unspecified anxiety disorder. Okay, I wanted to take just a few minutes here to talk about the issue of some sorts of treatment with anxiety disorder. Um, okay. I wanted to talk about some different types of treatment. I mean, I talked last week when we talked about depression about behavioral activation therapy, which is a behavior therapy for depression that often involves bringing up more positive aspects of the personal life, bringing more positive events in their life, and also the cognitive therapy approach. Um, and each week, I'll try when I can to talk about some specific interventions that are used for anxiety. I talked a few minutes ago about systematic desensitization, and I will get to that. But very often with anxiety, sort of the first stage is helping the person learn relaxation techniques, and relaxation techniques make up a large part of systematic desensitization because I have to talk about so I have to talk about the relaxation techniques first. Um, uh, there are a number of different relaxation techniques. Two of the major ones. One is called progressive muscle relaxation, and that's where the therapist teaches an individual how to relax. Sort of the general theme of uh, or the general theory of anxiety is that the opposite of anxiety is relaxation. And that relaxation is essentially allowing your mind and body to do nothing. And that's why, if you're at all familiar with mindfulness, it's why mindfulness also comes up as a way of addressing anxiety. Uh, it's almost like progressive muscle relaxation is the physiological um, alternative to anxiety. Mindfulness is the cognitive uh, opposite of anxiety. But progressive muscle relaxation is allowing your is learning how to get your body to relax. And it typically involves, and if you can find scripts for progressive muscle relaxation, and it often involves typically what it is it's each step is having the person tense and then release muscles throughout their body. So you are helping the person learn how to tense and then release different muscles throughout their body. And again, the theory here is that progressive muscle relaxation is learning how it feels to relax different parts of your body. So you feel what it's like when you're stressed, and then you feel what it's like um, when you release the anxiety, the stress in your body. So that's progressive muscle relaxation. Visualization is another approach to anxiety. And what visualization involves is um, it's sometimes called active daydreaming. Basically, you don't teach the person specific steps to relax. What you do is you have them remember relaxing times in their lives and basically have them relive those experiences. And very often, visualization is going through all the different aspects that would have been involved with those relaxing events. What did it sound like? What were the smells? What were the visions? So a very active remembering of um, things that were around when uh, when the person was relaxed. Basically, having themselves transport themselves mentally back to the situation that they found relaxing. So it may be a beach scene, it may be um, a favorite place in their childhood, sometime where they remember being fully relaxed, and then you take them back to that time and you have them re experience what was happening then. So those are two primary ways of relaxing. Now, if you think about it, what's interesting to keep in mind is it's probably with the relaxation techniques that you are almost doing verbatim what anti-anxiety medications would do. Anti-anxiety medications basically relax all the different parts of the body. They just do it chemically. And with relaxation training, you're helping the person sort of learn steps to do it on their own. Um, Now, mindfulness is probably one of the most, if not the most prevalent therapeutic techniques that are out there. Like you hear a lot about mindfulness for almost anything. It's considered a part of most major types of therapy, including um, acceptance and commitment therapy. It's considered to be central to acceptance and commitment therapy. It is a part of dialectical behavior therapy. Uh, it is a major part of all types of therapeutic interventions, mindfulness. And mindfulness is basically getting the person, it's often referred to as living in the moment, which is important, but it's also the person learning how to have an experience, but let it go without necessarily needing to respond to it. What happens with mindfulness is there's not an active fight against feeling anxiety. There's not an active fight against feeling emotional distress, but the general focus is on getting the person to have the experience but not feel a need to do anything about it. When I have seen individuals in therapy and talk to them about anxiety, I sometimes will talk about how uh, dealing with anxiety effectively can be like surfing, where when you're surfing, you're basically riding a wave. And what happens with riding the wave is um, you start at the top, and the only way you can successfully surf, as far as I know, I've never been surfing, but from what I understand about surfing, is the only way you can successfully surf is to fight the urge to do something. You're basically just trying to balance and keep things and keep yourself balanced, but you're needing to fight the urge to somehow fight the waves or fight what's happening. You just let it happen. And eventually what happens is the waves calm down and you're in shore. Um, that's what dealing with anxiety can often feel like. You know, you often are at your best if you don't try to fight it, you just let it be there. You acknowledge it, you let it be there, and then let the waves ride through. That's often what dealing with anxiety, how it can be most effective for an individual. And that's what mindfulness tries to get the person to do. Live in the moment, let the experiences be there, but fight the urge to do something about them. And then there's also cognitive therapy for anxiety. And this is very similar to the cognitive therapy we talked about before. Um, uh, some of the thinking when a person is anxious might be a little bit different. This is sort of the difference between, you know, anxiety and depression often have a lot of crossover. There's negative thinking involved. Um, Even some of the symptoms can be the same. People are depressed tend to be more irritable. People are anxious tend to be more irritable. Um, Anxiety, negative thinking with anxiety, uh, tends to be more along the lines of I have to do things a certain way. Things must be this way. Depression is more um, directed towards the self. I am no good. I will never be any good. Catastrophic thinking in that way. Anxiety often involves future thinking and involves more what we call all or none thinking. I must do everything exactly this way or else it's no good. There's a lot of have tos with um, anxiety. Um, I have to do things this way. If I don't do it this way, then it's wrong and I can't do something wrong. I can't make a mistake. Um, and very often with anxiety, um, addressing it on a cognitive level is getting the person to talk themselves through that logically. Well, what would happen if you make a mistake? What's the worst case scenario here? And it's this whole idea of helping the person recognize that it's not the end of the world if something happens different from how they think it has to happen. So with anxiety, there's a lot of have tos, and that's often the type of negative thinking um, that you have. Anxiety, as I said also before, um, is very often future focused. It must be this way or else it's no good. Okay. Um, let's talk about some different aspects about anxiety. Um, Anxiety disorders tend to develop before age 30. They tend to be more common in individuals who have a family history of anxiety and depression, suggesting there's a genetic um, part to it. Um, I talked a minute ago about different symptoms of the disorders, but let's talk specifically about what are some of the physiological symptoms of anxiety. Uh, Heart palpitations, restlessness, stomach trouble, difficulty swallowing, dry mouth, sensitivity to noise, headaches. You often hear people talk about stress headaches, insomnia, chest tightness. Those are some of the symptoms of anxiety. Um, and uh, they can be temporary, um, as might be the case with uh, they might be temporary, as might be the case with more of a panic disorder or social anxiety, or they may be long-standing, like would be the case with generalized anxiety disorder and selective mutism. Um, by the way, selective mutism, it's an interesting construct in that um, it's sort of assumed, based on a lot of research, that anxiety plays a role in selective mutism, almost like it's an extreme form of social anxiety. But because the person doesn't talk, it becomes difficult to identify exactly what's going on um, as far as um, as far as the person's emotional response and whether they actually are feeling anxiety. I want to talk about. Let me just summarize what are some of the major physiological terms associated with anxiety. I know they're in the book, and some of it can get a little um, detailed. Um, but some of the physiological terms that are important when we're talking about uh, anxiety. Uh, Benzodiazepine uh, is a type of neurotransmitter often involved with anxiety. Benzodiazepine. Um, and um, another type of neurotransmitter often involved with anxiety is GABA, GABA. Uh, so benzodiazepine is a type of GABA. They're the two, but they're two major terms that you hear used when it comes to the physiology of anxiety. Serotonin. So there's benzodiazepine, that's a type of neurotransmitter. Serotonin is another one. Um, Benzodiazepine and serotonin are two of the major types of neurotransmitters involved in anxiety, and they are both considered to be part of what is called the GABA system. So that's how that works there. The part of the brain that's often involved with anxiety is the amygdala, Amygdala, the amygdala. And that is the part of the brain that is involved with detecting, coordinating, and maintaining fearful emotions. Uh, so you'll hear a lot about the amygdala because it's a very strong, it's a part of the brain that has a strong um, um, impact on emotional response, fear, um, sadness, but in this case we're talking about fear. Um, so and what happens in so generally what occurs in anxiety is the brain um perceives something as a threat, and then what tends to occur is that certain neurotransmitters um, are released. Um, and um, what can happen in anxiety disorder is um, the level of certain transmitters that gets released um, are out of whack to what is actually happening. So basically, there's too much of a neurotransmitter, or the calming neurotransmitter isn't released in enough. So either the neurotransmitter that um, triggers that something's wrong gets released in too great of numbers, or the one that kind of calms things down and sort of counters the neurotransmitter that causes anxiety tends to not get released in great enough numbers. And so that tends to lead to a point of the person uh, feeling overwhelmed by the anxiety that's occurring. So, um, um, so what tends to happen is uh, and that could occur for a variety of reasons, similar to ones we've talked about before. It could be genetic, it could be biological. The person's whole biology may be off. And so that's what's causing the neurotransmitters to not work. Or it could be that the person's history has led them to perceive situations as being much more of a threat than might otherwise be the case. it is interesting to consider that when you look at the psychodynamic theory, and psychodynamic is going back to Freud, when you look at the very early stages of trying to understand psychological disorder, the first type of problem that was identified was anxiety. Freud talked almost exclusively about psychosocial development as being internal conflicts, and the internal conflicts cause anxiety. So depression could come about later. Uh, um, you know, anger outbursts, behavior problems could all come about later. But at the very base, in a lot of theory of where problems come from, is anxiety. In many theories, it's almost like depression and some of the other disorders are um, different manifestations of problems, but at the very base, the problems have to do with anxiety. So, anxiety is very much a major part of the base of psychopathology. It's interesting that the book we use talks about stress and mental disorders, and stress is often used as a synonym for anxiety. So it's just interesting to keep in mind that anxiety and fear is seen as at the very base of a lot of psychological disorders, and in fact, it's very much considered to be part of our animal nature. The fight or flight response we talk about a lot, and that's essentially anxiety. The fight or flight response. Something causes me to have something causes me to feel I am in danger, and so my body tells me to either run away or put up a fight. Um, because uh, that's what will um, that's what will get me out of the situation. Okay. Um, Two things or one thing I wanted to finish with was I talked last week about some of the major types of assessment they're used for depression. I just want to tell you there are two um, uh, well researched popular instruments that are used for measuring anxiety. One is called the the Beck Anxiety Inventory. I talked last week about how Beck has a Beck Depression Inventory. The Beck Anxiety Inventory is written by the same author. It's just for anxiety. Um, I've used it. One thing I'm not overly fond of is it tends to really emphasize the physiological aspects of it. So if you have somebody who, like for instance, difficulty concentrating is one, and certainly that can be a symptom of anxiety. Um, but it also could be a symptom of other medical disorders that don't have anxiety associated with it. So, if someone has a lot of medical problems, you have to sort of figure out, well, is this anxiety or is this specifically because of the medical disorder? Not because of anxiety due to the medical disorder, but is it just part of the person's medical condition? Another one that's interesting to talk about is called the State Trait Anxiety Inventory. State, STATE, trait, TRAIT. And it's interesting because it's an instrument that's used for individuals who have anxiety, but it's meant to measure more whether they just tend to get anxious in certain situations or whether they tend to be an anxious person. And very often, treating anxiety can be dependent on that. So, state means that they tend to respond to certain situations with a high level of anxiety. Trait means that they tend to be an anxious person who's just sort of generally anxious. So, those are two common instruments used for measuring anxiety. This seems like a good place to stop, and I'll look forward to see you at the next class.